right, Doctor. Mic is on and all yours.
All good. Look like everybody's going to be able to hear me okay?
Yeah,
Sweet.
good.
Okay. So, hey everybody, I got the pleasure of getting the anaphylaxis lecture today. So, bear with me. I just came off night shift, but we'll try to make it as entertaining and engaging as possible as we can today. So, anaphylaxis is a fairly simple topic, but requires emergent intervention, immediate recognition. And today we're going to just kind of discuss everything relating to anaphylaxis, all the way from recognition of what's going on with it, to pathophysiology, to treatment. Try to leave a bit of fun here and there, but we're also going to try to keep it engaging, like I said. So let's get right into it. Maybe. There it goes. There. So first off, just a little bit of introduction about me. I am Nathan Piccoli. I grew up in a tiny little town called Osceola in southwest Missouri. Actually came here to Joplin for undergrad at Missouri Southern. Then ended up going down to, that's perfect, thank you. Awesome. Yeah. Ended up going down to Fort Smith, Arkansas for medical school down at ARCOM. Been married to my wonderful wife since May of 2023, and then this little turd that you see here on the screen is about 15 months old, and we've got a second one on the way now. I enjoy running, watching a whole lot of NFL, playing video games, and then just recently started playing golf, and I'm absolutely horrible at it. So that's a little bit about me. Yeah. Didn't, no. There it goes. Sweet. And then one more little slide just about me. We got our in-home zoo, me and my wife. So there, that dog on the left was supposedly supposed to be a mini Aussie. Ended up being about a 50-pound Aussie, so I wouldn't call him so many. His name's Finn. We got our two cats, little fish tank there. Me and my wife are kind of reptile lovers, so I got that ball python, and my wife's got another ball python, and then the little crested gecko there down there on the right. So just a little bit about our home, and I figured this was appropriate for today's talk. So just some of my favorite scary movies, but. All right, now we got a little bit of introduction out of the way. We'll get right into what we're actually here to talk about today. So, yeah, here's our objectives. So first, we're going to define anaphylaxis and distinguish it away from, other less severe allergic reactions or even minor allergic reactions. We're going to try to understand the basic immunology as it pertains to allergy. We're going to understand the pathophysiology behind allergy. These last two that I just talked about aren't going to be quite as important today, but just understanding it'll make it make more sense here at the end with how we treat it. So also going to try to recognize common triggers, risk factors, and presentations. Going to go over the assessment, monitoring, decision making for you all, which you will be the first responders on site. I'm going to understand treatment protocols, monitor after treatment, and then we're also going to highlight some pitfalls about like what may cause problems to arise along the way, and we're also going to go through a couple case examples if we do have some time. So let's get right into it. So why is anaphylaxis crucially important? Maybe. There we go. So incidence is about 2.1 per 1,000 person years. It may not seem like a terribly large number, but this is kind of one of those things, anaphylaxis, that can kill people rapidly. So it becomes really important to understand. And then next, most of the reactions that were happening here today, as you're going to come to learn, happen outside of the hospital. So your crews and everything will likely be the first medically trained individuals to lay eyes on the patient and then begin the treatment. Most of them happen pretty quickly, so it has a quick onset. So most reactions actually develop within 1 to 2 hours of the exposure to the allergen. So you will be, and most of you likely have already had multiple times to be starting the definitive treatment for these individuals in the field. Next is the potential for them to deteriorate quite rapidly. Patients can develop airway problems fairly quickly, and with this, they have the recognized diagnosis and initiate treatment before it reaches the point of becoming dangerous. Can also get circulatory compromise and end up kind of crashing on you pretty quickly. So you all are kind of the most important part of setting the basis of how treatment goes in these people, just because you see them first. So what is anaphylaxis? It's a serious allergic reaction with rapid onset, may cause death, which requires immediate diagnosis and treatment. How do we define it? Well, we look here at this table here on the right side of the screen. Urticaria, which is just generalized itching, flushing, edema of the lips, tongue, uvula, skin developing over minutes to hours, associated with one of the following at least. Don't have to have multiple of these, only one of them along with the other skin findings. Respiratory distress or hypoxia, hypotension or cardiovascular collapse, and then associated symptoms of other organ dysfunction in some way or another, whatever that may be, whether it's urinary problems like incontinence, whether it's brain problems like syncope, or hypotonia. Two or more symptoms that occur within minutes to hours after the allergen exposure, so it also comes in pretty quickly. Thank you. So we got skin and mucosal, respiratory compromise, like we already kind of talked about, hypotension, persistent GI cramps or vomiting, which is kind of another one of the major findings that you're going to see in a lot of these people with anaphylaxis problems is GI symptoms that people don't really consider a whole lot normally. And then just consider this when they're exposed to any known allergen that they have a history of, which you all will hopefully be able to get history from someone standing around. No. Here, I can just do this. I'll just go stand there at the computer. 1 second here. There we go. Awesome. Oh, is it working now? Okay, gotcha. So now we're going to go into a couple things that are probably a little bit less important for y'all, but I feel like it might make the treatment section of this a little bit easier to understand. So bear with me on this next section. This next section is not very fun. It wasn't fun for me in undergrad either. So basic immunology. What are antigens to start off generally? Small molecules, often proteins or polysaccharides on the surfaces of cells, including viruses, bacteria, other particles that trigger immune response in the body. Pretty much the way you can think about these is pretty much just anything that has a 3D shape and is tiny. So oftentimes they're highly specific for whatever cell they reside on, and our own cells have them as well, but our body knows not to attack them in most cases. But when this goes wrong, that's when we get things like autoimmune diseases and everything like that. Like I said, apologize for what we're about to go through. Somewhat necessary to understand everything that's going on with the process. So, what are the two different types of the immune system? Innate versus adaptive, and we'll kind of get into what everything goes into between these two. So let's just dive right in. There we go. So this is kind of what I think of when I first heard of two different types of the immune system, because I'd never heard of that before. So it's kind of just confusing, but we'll get into it and try to understand it as good as we can. So antigen functions. When the immune system encounters an antigen, it doesn't really recognize as self, or else it recognizes it as something other than self. It initiates an immune response to create antibodies against that antigen or that substance. The antibodies bind to antigens and flag them for destruction by other immune cells. Antigens also act as name tags for the immune system to signal whether or not an object or cell is foreign. And then lastly, they kind of enable our immune system to create specific antibodies which are specific for those certain antigens, which allows faster response times for the next time we're exposed to these things that we've been exposed to in the past. So that's kind of just basic about what the 3D structure on the outside of a virus, bacteria, or even just an allergen in general, like pollen or pet dander, kind of causes generally as a response in our bodies on the molecular level. So antibodies, on the other hand, are what respond to those antigens that I was just talking about. So the general structure is kind of as follows. They're Y-shaped for the most part, unless you're talking about these two specific ones here on the end. So you've got IgA and IgM. IgA is kind of like a double-backed Y shape, and then IgM is 5 Ys if you stuck the tail of them together like that in a circle. Pretty much the only reason they're shaped like this is just based on what function they have. The fork of the Y, or the top of the Y, acts as the binding portion to the antigens themselves on those micromolecules that we get allergic to, while the tail of the Y often binds to immune cells to initiate immune responses and kind of tells those cells what they need to be doing. They go through a development process which is strict in most of our bodies to prevent antibody from recognizing our own cells, or i.e. therefore preventing autoimmune diseases. Different functions that we'll talk about here, each one. So IgA, secreted into mucus, saliva, tears, colostrum, tags pathogens for destruction. So really a lot of these IgA molecules are just kind of secreted into our mucous membranes, and then that's where the immune response starts when pathogens get into our body, is most of the time mucous membranes. IgD, this is a specific one that we'll talk about a little bit later that's specific for B cells, and it just sits on the surface of B cells. We'll talk about that here in a minute as well. IgE is another one that's going to be the most important for today. This is the one that binds to mast cells and basophils and causes actually most allergic reactions and anaphylactic/anaphylactoid reactions. IgG is probably the most important one in our body overall, just because it is the main antibody for secondary responses caused by T cells and B cells alike. Also binds to phagocytes, which are just cells that engulf bacteria and viruses. IgM fixes complement. Complement is a set of proteins in our blood that help to destroy pathogens. It's the main antibody of primary responses. Kind of acts as a B cell receptor as well, and then it participates in memory of our immune system as well, which we'll get into a little bit. So let's talk about those two different types of the immune system now. The innate immune system, it's the first line of defense against infection. It's the fastest of the two, works super quick, does not require prior exposure to an allergen or an antigen to work. Acts against generally foreign antigens rather than specific memorable ones that our body has seen in the past. And then we've got all of the contents here of the innate immune system. We've got physical and chemical barriers, which include our mucous membranes, skin, stomach acid, antimicrobial enzymes. A lot of people don't really realize that these are parts of our immune system, but they are one of the actually main important parts to keep us from getting sick or getting an allergic reaction. We've also got cellular defenses like neutrophils, macrophages, NK cells, dendritic cells, mast cells, and basophils. All of these are just different types of cells that we'll very briefly talk about on the next slide, because most of them aren't super important for anaphylaxis. And then we've got also molecular responses, which we kind of already touched on a little bit. So here's the innate immune cells. Neutrophils, first responders, engulf and digest pathogens, degranulate antimicrobial substances, regenerate reactive oxygen species. Macrophages, largely just a phagocytic cell that sit in tissues waiting to engulf things that are not good, like bacteria or viruses. NK cells, largely useful in destroying virally infected cells. Dendritic cells, similar in function to macrophages. Mast cells are one of the major ones we're going to talk about today. This is kind of the big pathophys part of what we're going to talk about. They coat themselves in IgE, and then when the IgE binds to them, or when an allergen binds to the IgE, they release an inflammatory response which mediates allergic reactions, and that's what kind of causes anaphylactic/anaphylactoid reactions. And then basophils act similarly to mast cells. Eosinophils are more worried about parasitic infections, so we won't worry too much about them. The adaptive immune system, on the other hand, is slow like the tortoise, works much slower than the innate immune system, but the advantages to it is that it's highly specific, recognizes millions of different antigens, and is very good at remembering each of them specifically, can encounter antigens which it has not encountered in many years, and still produce a very highly specific and highly effective response to that allergen. So that's kind of how we can get infected with a virus when we're young, and then encounter it again years later, and it doesn't hit us as hard the next time in most cases. Mostly the contents of the adaptive immune system are going to be just specifically B and T cells, which we classically call humoral immunity for the B cells and cell-mediated immunity for T cells. So here they are. T cells, there's different types of these. Helper T cells coordinate immune responses by directing other immune cells through chemical signals like cytokines and other things. Cytotoxic T cells kill tumor-infected or virally infected cells to cause cell death. Regulatory T cells suppress autoimmune processes that hopefully prevents things like type 1 diabetes. Memory T cells persist for many years after an infection to remember the antigens after future exposures, like we were talking about a second ago for the memory that our immune system has. So B cells, these turn into what are called plasma cells after activation from contact with one of the antigens or allergens. They produce antibodies which present, and then they actually present those antigens to T cells, and T cells are kind of the workhorse of how our adaptive immune system works. So now that we've got through basic immunology, we're going to actually start talking about what's important today, which is anaphylaxis. So the basic pathway kind of works like this. Activation of mast cells and basophils is the general process for what happens for anaphylactic or allergic reactions in general. It starts with the cross-linking of IgE, or those Y-looking little proteins, to multiple antigens. So if we say that there's 3 antigens out there and we have 6 IgE molecules, or the other way around, multiplying and kind of binding to each other, that's what kind of activates the process. Upon binding of the tail portion to these, there's an antigen binding portion and the tail. Like we talked about earlier, the cross of the Y is the antigen binding. The tail is what binds to the mast cell. It activates the basophils or mast cells to release their chemical mediators, which are stored in secretory vesicles. They include histamine, tryptase, proteoglycans, and carboxypeptidase. I know it's a lot of big words. Most of these really aren't that important, but the effect of what they do is what's important and what causes the anaphylaxis. All of these mediators just activate downstream enzymes like lipoxygenases, phospholipase A, cyclooxygenases. These produce more metabolites that are leukotrienes, prostaglandins, platelet activating factor. None of this is important for you all. Just know that all of these cause downstream effects, which lead to the clinical presentation of what's going on. Histamine, which here's the important part. Histamine causes vascular permeability, vasodilation, heart rate increases, cardiac contraction. Prostaglandins promote bronchoconstriction, pulmonary and coronary vasoconstriction, peripheral vasodilation, or further vascular permeability. Leukotrienes and platelet activating factor are potent bronchoconstrictors. Anaphylaxis and anaphylactoid terms have kind of fallen out of favor, and you've heard me mention them a couple of times previously here. And the reason for that is because it's really not important. Originally, it was an anaphylactic reaction if it was IgE mediated by those specific antibodies, and it was an anaphylactoid reaction if the mast cells were activated independent of those antibodies linking and cross-linking. The reason that that's fallen out of favor is because it doesn't really matter what causes it. The person's having the exact same reaction no matter what is going on, because these mediators are being released and causing a systemic effect. So that's kind of where we're at with what's going on and what's causing all of this. So anaphylaxis versus mild allergic reactions. It's a fairly simple difference, really. True anaphylaxis is just going to be more severe, is the kind of brass tacks of it. The person will likely not be able to breathe if they're in true anaphylaxis, and they're just going to have multiple systemic symptoms. Milder reactions, person won't be nearly as sick, won't look nearly as sick. Just based on when you first get there, they will not be near as much as distress. So let the look of your patients when you show up on the scene kind of help you determine and make a good judgment call on whether or not we've got anaphylaxis actually going on or not, or whether it's just a milder allergic reaction. So let's go into some common triggers. Foods are some of the more classic triggers that we all hear about. We normally get the classic, story that a kid went to a birthday party, ate a brownie right before, didn't realize it had nuts in it, and then here we are, a kid that's, breathing 70 times a minute and saturating at 70%, and they just look horrible. That's the classic sign, or the classic story that we always hear. But there's a lot of things that can cause it. And these are kind of the more common food triggers. So apart from just peanuts, you've also got eggs, fish, milk, sesame, shellfish, soy, tree nuts, and wheat. And, some of these are more common than others. It feels like everybody and their mother has a shellfish allergy, or is allergic to dairy of some sort. But these are kind of just the more common food ones specifically. And then we've got, well, maybe. Boy, it jumped far ahead there. There we go. So other common triggers we've got here. Medications is the first one. So obviously I was going to ask for examples of medications, but there they are on the screen. So we've got antibiotics, aspirin, NSAIDs in general. Chemotherapy is another common one, anticonvulsants, monoclonal antibody therapies, and some of these are used to treat asthma and eczema, which are, allergic reactions somewhat, or autoimmune problems. But Either way, a lot of these, as you can see, like the monoclonal antibody therapies, those are tiny little proteins which have the tiny little 3D structure that we were talking about with antigens, which makes sense as to why they would cause an allergic reaction, because one of the antibodies in our body is specific for that antibody that it's targeting. Other thing is venoms, and this was kind of one of the things that I found was interesting. Does anybody know what the most painful sting in Missouri is? Rated as a 4.0 out of 4.0 on the Schmidt Index Pain Scale is the tarantula hawk. I had no clue we had tarantula hawks in Missouri, but apparently we do.
What the heck's a tarantula hawk?
Did you get one? Did you get stung by one? What was it? No, it's a wasp.
The wasp.
Yeah, but they call them tarantula hawks because they hunt tarantulas. So it's pretty interesting. I mean, yeah, it's a wasp for eating a tarantula. Yep, yep. It's interesting. But 4.0 out of 4.0 on the Schmidt Index scale. No, that's just a random mud dauber or something. But the 4.0 out of 4.0 is regarded as on their website, pure, intense, brilliant pain is how they describe it. So, and then lastly, another common trigger that we always see is just latex, which we hear of a lot of people having latex allergies as well. But yeah, tarantula hawk. And then just to prove I'm not lying to you about the Schmidt Pain Index, here it is. We've got common things like sweat bees, fire ants that are kind of lower down on the list. And then obviously everybody's always heard about the bullet ant. So that's rated down there way at the 4.0 plus. So just to prove I'm not lying to everybody, here it is. I don't know what it really means because pain's kind of relative. So there it is though. Okay, so risk factors for fatal or severe anaphylaxis. So what are some things that we normally, think of as causing more severe problems or being risk factors that lead to more severe problems? So the first one is going to be delayed initial epinephrine. Obviously, this one's pretty self-explanatory. The longer the time delay from the time that we recognize an anaphylactic reaction to the time we start treating it is not ideal. If we take the time to wait and get that first line treatment started, the more severe the problem is going to be, and then the more epinephrine it's going to take to get the person back. And we'll talk about epinephrine as a first line treatment here shortly. Next, we've got unknown triggers. This is kind of one of the weird ones. It just means that we may not be able to decontaminate the person completely. And we don't think about decontaminating people after they eat something, because we're not just going to go and gastric lavage everybody who eats like a peanut or something if they're allergic to them. But if there's an unknown trigger and we don't know whether it's through skin or they breathed it in or they ate it, it makes it a little bit harder to treat, obviously, if we can't decontaminate the person immediately. So that is kind of the reason there for why that's a risk factor for it being more severe. Prior biphasic reaction, and that's kind of what this little chart down here in the bottom right is depicting. So this just means that the reaction comes with a first wave and then a second wave after the initial reaction. So here at the -4 mark, we have the initial insult. The response starts going up. We give them the first dose of something. They start getting better there in the middle around the -1 to 0 mark on the x-axis. And then they start having symptoms again. And any history of having these biphasic or multiphasic reactions to the allergen that they're allergic to just increases the risk for them to have a fatal or severe reaction to that allergen. And then the last one is just need for greater than 1 epinephrine dose. And that kind of just ties in with the last one being the prior biphasic reaction. If they're having a biphasic reaction, they're going to need more than 1 epinephrine dose. So that one's also fairly self-explanatory. And also the need for more epi just means that it's a more severe intoxicant at that point anyway. So pretty self-explanatory on that one as well. So now to the meat and potatoes of what we're going to talk about and the actual important stuff for everybody here. We got the clinical presentation. So we're going to start with airway and breathing, because that's kind of the thing that we always get worried about with our ABCs, and that's what we worry about first with people, except in ATLS now, apparently exsanguination is first. So ignore that part. So airway breathing. A lot of the things that people are going to complain of is a sensation of fullness in their throat, tightness in their chest, shortness of breath, hoarseness, laryngeal edema, stridor, wheezing, all of the above things. A lot of the times you'll actually be able to hear the stridor or hear the wheezing whenever you show up on site if these people are having true anaphylactic reactions. And then these pictures here are just kind of some things that you might see. So you see that person there on the right has severely swollen lips, mouth, face going on there. And then the pictures there on the left are kind of just pictures of what you might see if you end up having to intubate somebody. So the top one's obviously pretty normal, and that's what we see, on a lot of intubations. And then the bottom one is just significantly edematous tissue there in the larynx. So that's what you don't want to see. And if they have that severe of swelling, they're probably going to need a tube sooner rather than later. So next we've got circulatory problems. So obviously, we've got hypotension, tachycardia, fainting, collapse, shock. These are kind of the classic findings for a person who's in shock. And anaphylaxis is a type of distributive shock. So that's kind of where we're at here to understand that. I put this picture up, just because I kind of had trouble like reading EKGs before I kind of got into residency, and now that I've seen a bunch of them, it makes it a lot easier. But obviously with the rate, we count big boxes, 300, 150, 100, 75, 50, as it goes on and so forth. So obviously the rate here, it's a little bit less than 2 boxes. So if 2 boxes is 150, we're just going to go a little bit higher than that. We'll say 170, 180, somewhere around there. Is there a P for every QRS? Indeed there is. We've got 2 little bumps between each one. They don't look crazy spaced out, different from each other, so it's fairly regular. There is a P for every QRS. What is the pattern of the QRS complexes? Are they narrow or wide? Well, those look fairly narrow to me. Not big and wide, doesn't look like, VTach, VFib, anything like that. So what's the name of this rhythm? It's just sinus tachycardia. Pretty simple one, yeah, but that's what you're going to see on these people. Because this is not, a primary cardiac issue. It's an issue from leaky blood vessels, and their heart's going to increase in rate to keep up and maintain their blood pressure when their blood pressure is trying to fail them in their distributive shock. So that's kind of what you'll see on EKG in these people a lot of the time. So other we've got here, and these are kind of the ones that people think of as being less important, but they are important because it helps us determine whether we are having a true anaphylactic reaction or not. So the cutaneous problems may not always be there. A lot of people think that when there's going to be an allergic reaction, they're for sure going to have hives and they're for sure going to have itching, but they don't necessarily have to. But most of the time, hives are what we see here. Obviously, the medical name for this is going to be urticaria. And then we've also got flushing, or just redness of the face, extremities, everything like that. And that's just because we're leaking all that hot blood or all of the plasma and everything from our blood vessels into our extremities, making them warm. So then we've also got GI problems, which we were talking about earlier. This is one of the things that a lot of people don't consider really when they're thinking about symptoms of anaphylaxis. But nausea, vomiting, and abdominal pain are extremely common in people who are having true anaphylactic reactions. So pre-hospital assessment. Obviously, we always want to start with rapid ABCs. Airway, breathing, circulation is always first. Next, vitals. So obviously, vitals are vitals for a reason. It's important to get a quick glance at people, see how they're doing, but then you immediately need to get vital signs. And that's kind of where this fun little picture came in here on the right. I thought that was pretty funny. But then sample history. This is kind of one of those things that I didn't really know was such a big deal before I took my ATLS course. But apparently in your guys' world, sample history is like a huge thing, I guess, from what I hear. I didn't even know what it was, but I guess I'll go through it even though you guys probably already know what it is. So symptoms, allergies, medications, past medical history, last oral intake, and then events leading up to the current illness. Why is each important? Well, subjective findings such as their symptoms are, one of the main importance as to what we as doctors do in the emergency department. I think there's a stat out there that says about 80% of medical diagnoses come from just subjective findings that the patient tells you about, and then physical exam and labs, imaging and stuff makes up for the rest of that. Other than that, obviously, we don't want to give somebody a medication that they're allergic to, so that's pretty self-explanatory as to why that's important. Medications help us determine whether or not there could be interactions with our treatments. Maybe they're not able to mount a significant, tachycardia response to their hypotension because maybe they're on beta blockers. So that's another thing we have to think about. Past medical history, obviously, if they've had, if they've got AFib or if they've got diabetes, obviously these, chronic medical problems can affect how their hospital stay is going to go. And then last oral intake, I'm going to be honest, I don't really know why this one's so important. If a person's super, on the sick side of things, I don't really care a whole lot about what the last oral intake is. I know surgeons do care a lot, but if a person is coming in, coding or something like that, I'm not quite as concerned about what they ate last. I'm concerned about why they're coding. But that one's in there. And then events could tell us, what's possible for the trigger to, or what triggered the episode of what's going on. Anaphylaxis, that one's huge, obviously, because if we have the events of what led up to it, we know that the person ate the brownie that had peanuts in it, or we know that the person was out on the playground when they got stung by a wasp. So for this talk, that one's very important. So, immediate initial management and positioning. Obviously, we always want to put legs up to return blood flow to the heart if they're hypotensive. This just increases, perfusion to all of the rest of our body and everything like that. Keep them supine or flat unless they're in respiratory distress, and then if that happens, you can kind of keep them in the semi-upright or just raise the head of the bed a little bit so that can help them breathe. Other than that, just avoid making the patient stand, because if they're hypotensive, they're going to fall. They're going to hurt themselves even more, which is definitely not what we want. So don't try to stand these people up. Just pick them up and move them to wherever you need to move them to. They're also not going to want to get up and walk around when they're breathing at 35 times a minute either. So equipment you'll need. Obviously, you guys carry these every day. This is kind of just little thing here, but SpO2 sensor, obviously we want to know how somebody's oxygenating, airway adjuncts in case we end up needing to give somebody an ET tube or put in a supraglottic airway, or even just give them a simple face mask, or even nasal cannula. IV access, obviously that's super important. We love it when you guys bring them in and you already have IV access at the hospital. That's very helpful, especially in people who are super sick like this. Monitors like an ECG or a blood pressure cuff, and then obviously medications, which we're going to discuss later, which you all will always have on hand. So now we're going to go into some things that can kind of look like anaphylaxis, and you got to be on the lookout for. So a lot of things can look like it. Get a good history. Above all, just take care of the patient. At the end of the day, making the diagnosis is a lot less important in a person who's critically ill than saving their life is. So just keep that in mind. The differential diagnosis includes flush syndrome, which there's a lot of things underneath this. Can include autonomic epilepsy, carcinoid syndrome, medullary thyroid carcinoma, adverse reactions to drugs. Then we've got the hypotension category, which could be from cardiogenic shock, hypovolemic shock, septic shock, vasovagal reaction. Could also just be from a different kind of distributive shock. Miscellaneous, anxiety, panic attacks, hereditary angioedema, leukemia with excessive histamine production. All of these things can produce a response that's similar to anaphylaxis. Postprandial collapse. We've got airway foreign bodies, scombroid fish poisoning. Apparently that releases a bunch of histamine. I don't know. I'd never heard of this before I started making this, so I thought that was pretty interesting. And then obviously respiratory distress with wheezing or stridor. We know all the classic things that can cause this. Obviously COPD or asthma exacerbations, vocal cord dysfunctions, and children could be upper respiratory infections such as croup. You just never know. But these are kind of your all's bread and butter with the respiratory distress. You know all the things that cause that. That's what we get from you all very frequently. So, all right, who is this? It's going to hurt my heart if nobody knows. It's Bruce Buffer. Bruce Buffer. I like the UFC. So, but anyway, now it's time for the important part of this talk. We're going to go into the treatment, which is kind of what everybody's been waiting for. So let's get right into it. Obviously, we've kind of already spoiled it a little bit. First line treatment, we already talked about epi. Well, how does it work? So we've got maybe there we go, mixed alpha-1 and beta receptor agonist activity. So our alpha-1 activity reduces mucosal swelling, treats the hypotension through vasoconstriction and peripheral blood vessels. Well, there just knocks out two of the really important things that we need right off the bat. Then we've also got the beta-1 activity. So this increases heart rate, which questionable, but if you're trying to bring their blood pressure up, that's going to increase their cardiac output. And then it also increases cardiac contractility, which obviously, like we talked about, counteracts the hypotension and shock. Then we've got beta-2 activity, which is kind of the workhorse of the beta work that we're wanting, which promotes bronchodilation and limits further mediator release from the anaphylactic reaction, such as the histamines, leukotrienes, everything like that. So dosing. For adults, zero point 0.3 to zero point 0.5. A lot of the recent data has suggested that zero point 0.5 is actually superior to what zero point 0.3 is based on all of the literature that's come out. That doesn't really mean anything because the auto injectors are still 0.3. So we'll talk about IV epi and everything like that. I don't know. Do you all carry IV epi or do you just use auto injectors in the field? You use auto injectors? Okay, perfect. Oh, you don't? Awesome. Okay, cool, perfect. So 0.5 is going to be the preferred dose in an adult nowadays. Like I said, most of the new data is coming out saying that 0.5 is actually preferred, but the auto injectors haven't caught up with that yet. It doesn't sound like. And then pediatric is 0.01 mg per kg. And any kid that's over the age of 10, 5, they're going to be pretty close to an adult dose, but knowing that it's less is the important part. So root. Always going to give IM if you're using the auto injector, obviously, but it sounds like all of you all have the ampules and you give IV a lot of the time. So obviously you all are very, very familiar with giving IV, but everything I read was like, well, be sure you tell them that they have to be careful with their dosages of IV unless you're experienced. You guys have way more experience than I do. So
That's a very true thing. The 1 to 1,000.
Yep.
It's absolutely different than 1 to 10,000.
Exactly.
1 to 1,000 probably shouldn't go IV ever.
For sure. Yep. So as he was explaining, is there's different concentrations of epi that you can get. So that's why I kind of put this little note in here about being careful with the dosing. You have to make sure that the concentration is right for the volume of epi that you're going to be giving. And then timing. Holy cow! Just jumped again on me. Either way, timing goes pretty much every 3 to 5 minutes. So it's just a few slides, I think. But every 3 to 5 minutes is when you're going to be able to repeat it if you want to. Just a little on a side here. There are many studies that suggest that epinephrine is like underused, suboptimally dosed, underprescribed for people at home. Don't be afraid to give it. It's the first line treatment and it's what people need. So just don't be afraid to use it. A lot of people kind of underdose it or are afraid to give multiple doses. So just don't be afraid to do that. Other than that, that's pretty much all that there is about epi. And I think it's back like one more. Yeah, there we go. Perfect. Yep. Let's see if it'll work. Awesome. Okay. So then obviously we've just got a few little kind of pictures about how it works. Obviously, if you're going to end up using the auto injectors, you got to, pull it out, remove the cap. The orange tip goes toward the patient's thigh. You aim for the anterolateral thigh right there, kind of midway down the femur, and then you smack it into them. Wait 3 seconds, and then it says here, call 911, but unfortunately you all are 911, so I wouldn't recommend picking up the phone and calling 911. So, and then if we're going to give IV, I know it's a little bit small, but pretty much the first few lines are just verify the dosages. This is still going IM. You all give IM, or do you go IV if you have access? With okay, gotcha. Okay, so obviously IM still in the anterolateral thigh. That's what's recommended still, and then obviously get rid of your sharps. Don't want to stab somebody. So. When to give more epi, kind of like we talked about. If they're still having symptoms and they're still having trouble breathing and they are still throwing up and nauseous and they're still breathing at 45 times a minute, they need more epi if it's been 3 to 5 minutes. It's one of those things that I feel like, based on what I've read, it seems like it's just underused and underutilized for repeat treatments. So if the person's still having trouble and they still look like garbage and they're still shocky, just give them more epinephrine. Really, the only thing that you're going to cause with the epinephrine is their heart rate's going to go crazy and their blood pressure is going to go up if you give them a lot of it. And at the end of the day, I'd rather somebody be hypertensive than hypotensive. So just give the epi if they need more is kind of the brass tacks of this slide. There we go. Other first line treatments, and I put this in quotations because some things consider these first line treatments, some places consider these adjuncts. Either way, it doesn't really matter. So O2, obviously securing the airway is a first line priority after you've given the epi. So examine mouth and pharynx for signs of angioedema. If anything's producing respiratory distress or anything like that, just intubate early. Fast development of symptoms is the reason for this. Decontamination. If somebody eats something like I talked about earlier, don't just go and pump their stomach. We don't do that. But if they, like this picture on the right, that's a bee stinger. So if you know that somebody got stung by a wasp or something, pull that bad boy out, because even though it's been removed from the wasp or the bee, it can still deliver venom when it's been removed and it's still sticking in your arm. So if you see that, wipe it off their arm, get it out of them. It's just going to continually give them their allergen if you don't. And then IV fluids. Obviously, this is really only important if the person is hypotensive, but just it's kind of one of those possibly first line, possibly adjunct. But if they're hypotensive, you definitely want to start fluids in the field. Secondary treatments, all sorts of them. I'm just going to briefly talk about them. So the difference in H1 and H2 blockers is that H1 is mostly involved in allergic reactions, whereas H2 receptors are mostly involved in gastric acid secretion. But using them both in combination is highly effective to treat allergic symptoms. Obviously, corticosteroids inhibit immune responses and decrease the release of inflammatory mediators, so those are good too. And then you can use like duonebs for bronchospasms and stuff like that as well. Glucagon, wouldn't really worry about too much. Really, the only time we really care about that is if they have beta blocker poisoning on top of their anaphylactic reaction. But these are just kind of things that to think about, and not as important because we can always give these when they get to the hospital. But the main importance for you all is just keeping them alive, keeping them oxygenated, and giving the epi. So things to document and tell us. This is one of the things that I just love, because I love it when y'all come in and there's a great report. It's so awesome. So time of arrival at the scene and time of the call. I love it when we get this information, because I know what happened and when, and I know, it's been 25 minutes since this started, or it's been 3 hours since this started. Relevant history, obviously we talked about, that's super important for this, because if we know they've got a peanut allergy and they ate a brownie with peanuts, there's the problem. What the trigger was, obviously, first epinephrine dose and time of it, any subsequent doses, and then responses of each of those. How much you've given total is also important. And then if you got vascular access, and then obviously vitals as well. We're gonna skip this video because I put this in here just in case we were gonna have time for it, but we'll skip this for now. It's just a 3-minute video kind of showing the pathophysiologic process, so not hugely important right now. Didn't want LinkedIn anyway. So we've just got kind of some case reviews now to go over here at the end. So these are kind of just like quick and dirty things about here's what's going on with the patient, here's where you get dispatched to, what are we going to do about it, everything like that. So let's just jump right into case number 1. So you get dispatched to a local park for a 27-year-old female with difficulty breathing and hives. Call was made by a bystander stating the patient was having a severe allergic reaction. So what do we want to do and see when we get there? This is kind of a read my mind question, so sorry about that. But obviously, the first thing I obviously do when I walk into a room in the ER is I want to lay eyes on the patient. I want to see if they look like garbage, if they look like they're about to croak, see how bad or how good they look sitting there. So if that's what we're going to do first, you show up to the scene, and this is the lady you see. She's sitting on the grass, visibly anxious at the park, scratching at her neck, arms, chest. Speaking in short sentences between breaths, obviously breathing super fast, super hard, can't really catch her breath, can only get one word out at a time. Red splotches all over her face like you see here, all over her arms, neck, and chest, and then obviously her lips appear swollen. It's pretty easy to see on this one. So always take a glance at the people before you do anything else or worry about anything else, because if you sit there worrying about history while you're just letting this ride, that's not what we want to do. So obviously this lady's going to need resuscitation likely pretty quickly if what we suspect is going on is true. So here's our initial set of vitals when we get there. Heart rate 122, blood pressure 94/58, respiratory rate of 28, oxygen saturation 91% as she's sitting there in the park on room air, and then temperature is 98.2. Well, there's a few things about this I don't love. Heart rate's super high. For what reason? Blood pressure is pretty low, pretty soft. For what reason? And I don't love people breathing at 28 by any stretch of the imagination. And then in a young, healthy person, 91% on room air is also not great either. The friend that's sitting there and was having the picnic with her looks at you, says she ate a cookie about 10 minutes ago that had peanuts in it, has a known peanut allergy, wasn't aware that there was peanuts in the cookie, usually carries her EpiPen with her, but today she just didn't have it on her. No asthma or heart disease history, and she's otherwise healthy, doesn't have any chronic medical problems. So is this anaphylaxis? We'll get into it, but we'll also describe, why or why not and what the immediate priorities are. So obviously this is anaphylaxis. The patient has many signs of allergic symptoms, including the hives, itching, swollen face, along with the hypotension, difficulty breathing. She needs immediate treatment. So immediate priorities are going to be assess the need for airway and then prepare what medication. Well, obviously we're going to do epi. It's kind of the main point of the talk today. So how much are we going to give? Obviously 0.3 to 0.5, already discussed that. Probably 0.5 since this is an adult lady, and we talked about how 0.5 is kind of the preferred dose nowadays. So what other adjuncts do we want to think about? Well, they're hypoxic, so let's give them some oxygen via nasal cannula, get IV access, get some fluids started for that blood pressure, and then we'll see what happens. We'll see if we need to, elevate further from there. We'll see what the epi does, and we'll go from there. Could consider the other adjuncts. That's not something that I really worry about immediately. If the patient starts to stabilize a little bit on the way here, could give some stress dose steroids. But obviously, we need to prepare for definitive airway placement in case the epi doesn't work or the oxygen isn't helping at all, and the patient starts desaturating more, breathing faster, having more work of breathing, everything like that. And then obviously if you hear if you hear audible wheezing, or if you hear it with your stethoscope, listening to their chest, you can give them an albuterol treatment and see if it opens them up a little bit, makes it a little bit easier for them to breathe. So congrats, saved a life today, strong work. Patient stabilizes, starts to feel better after the epi and some supplemental oxygen. Thanks you for your time. You drop her off at the hospital. She's doing great. What information are we going to give to the ER team when we get there? Good handoffs are always important, like I talked about. 27-year-old female coming from the park with complaints of hives, started, 10, 20 minutes ago, however long it was. Swelling, difficulty breathing, hypotension, ate a peanut, which she has a severe allergy to, didn't have her EpiPen on hand, got there immediately, gave epi, give the time and dose, put her on oxygen, administered whatever other adjuncts we did. She did improve after the first epi dose and has been stable since. Initial vitals were this, they stabilized to this after the epi, and then that's what we've got. So there is our first case. Let's go straight into case number 2. You get dispatched to a local restaurant for a 35-year-old man with an allergic reaction thinking that he's having anaphylaxis. He reports itching and redness after eating shellfish. So once again, kind of the read my mind question, what do we want to do first? We already kind of talked about this. Let's take a look at him, see what's going on, see what he looks like before anything else. That's what he looks like right there. He's alert, oriented, speaking clearly in full sentences. He's got some mild redness with urticaria visible on his neck and forearms. No facial swelling, drooling, stridor, respiratory distress. Not complaining of nausea, not complaining of vomiting. Otherwise, looks okay. So, what do we want to do next? Obviously, we will grab some vital signs. Heart rate's 88, blood pressure is 128 over 76, respiratory rate 16, saturating 99% on room air, temperature is 98.4. History from the patient, known shellfish allergy. This feels the exact same time as it did the last time that he ate some shellfish. He tried taking some Benadryl because he was worried he'd stop breathing if he didn't. No medical conditions otherwise. So, question of the night, is this anaphylaxis? Why or why not? What are immediate priorities? Nope, no anaphylaxis here. Mild allergic reaction, and we know that after this presentation, obviously, because there are isolated skin findings in a stable patient with no GI, circulatory, or pulmonary issues. So, should we give epi? No. Epi is only indicated in anaphylactic reactions. This is obviously a milder allergic reaction. No epi needed here. So provide reassurance, deliver to the hospital. You can consider the other things like we talked about, antihistamines, steroids, but otherwise there's no life-threatening reaction at this time. to worry about. Can give reassurance to the patient, let them know we'll take them to the hospital, get everything treated there. Maybe. Here we go. As we're holding the epi, obviously we're going to give a good handoff one more time, and then we will go about our day, head on to save the next life. So we'll get one more case in here. So you get dispatched to an elementary school playground for an 8-year-old boy who had a sharp pain on his arm before developing difficulty breathing. School nurse reports swelling and hives on the call. So what do we want to do and see first? Obviously, we're going to take a look at the kid. Sitting upright, anxious, crying in the nurse's office. He's got audible wheezing, mild stridor, facial swelling around the lips and eyes. Hives are visible on his arms and chest. Nurse reports that the patient was complaining of his throat feeling tight. He has no known allergies. Teacher reports that's in the nurse's office with you. Teacher reports there's a wasp nest tucked away in the rock wall on the playground near where the child was playing. And they've known about it for a while, but they haven't been able to go out there and do it, and haven't had the staff go out there and do anything about it yet because it's kind of hard to get to. So, what next? Vitals. Heart rate 132, blood pressure 84/50. So as you see there, is this a normal blood pressure for a kid? Because I feel like that's another thing that kind of gets, just swept under the rug, is something that's easy to figure out or not. Well, maybe. It's probably low. How do we know that? This is our kind of fancy little quick calculation that we've got here. So the fancy little calculation is 70 plus 2 times the patient's age. If the patient's 8 years old, 2 times 8 is obviously 16. 70 plus 16, 86. So that systolic's, right there at the borderline. But if you've got a blood pressure that's at the borderline in a case like this, just assume it's low. So therefore, 86 should be the low end of the normal systolic pressure in an 8-year-old, so we'll just assume this is low and that the patient's hypotensive. Respiratory rate's 32, oxygen saturation is 90% on room air, temperature is 98.1. School nurse thinks the child was stung by a wasp based on red swollen area on his arm before all of the hives developed and all of the problems developed. Has no known allergies, no medications have been given yet, no history of any chronic illnesses, no NICU stays, nothing like that. So is this anaphylaxis, and what are the immediate next steps? Yeah, obviously, this kid looks like garbage. He's hypotensive, he's breathing like crazy, and he's just in distress in the room. So what med are we going to give? What dose? What route? Obviously, we're going to do epi. It's kind of the main thing here. We're going to give 0.01 mg per kg. He weighs 30 kilograms, so he could get the auto injector if he really wanted to. It's close to the adult dose, but really his appropriate dose would be 30 milligrams or 3 milligrams. Obviously, we're going to give it in the anterolateral thigh because that's what we always do. What else? Support his breathing with O2, like we said, nasal cannula or mask if you can tolerate that better. Prepare to intubate if needed if it gets worse. Stress dose steroids plus or minus if we've got time. If he's stabilizing a little bit, maybe some H blockers. Stable until reaching the hospital is the main priority here. So other than that, same report as always. We're not going to go through it again with the good report. You all know how to do that. We always get great reports from you all. But good report is very crucial. So recap. Understand the physiology because it makes it easier to understand why we're giving epi and what the epi is doing for us. Recognize anaphylaxis early because recognizing it early, as we talked about, will lead to better incomes, decreased mortality and morbidity. Treat early. Give the epi as early as possible. Give the epi as often as possible. If they need more epi, don't be afraid to give them more epi. There's that. Don't ignore the adjunct treatment options. If a person needs supplemental oxygen, give them supplemental oxygen. If they stabilize a little bit after you give them their first dose of epi, give them the stress dose steroids. It seems like we have that happen a lot when we come in, and we love that because then we don't have to worry about giving them more steroids when they come in. You guys have already gotten that part done, so that's awesome. And then obviously full good report like we've talked about, and then that's kind of it. So here are the resources that I used, and if anybody has any questions, I'd love to answer them.
Hopefully we get a little bit of a response. They're 20 or 30 seconds behind. No, you're good. So I got to put it on now. questions, keep routing and let's see. Great lecture.
Appreciate you.
I thought you were going to go way too fast and be way short, but holy moly. It was a lot. It's great. That's great.
Alrighty, y'all. I appreciate you for your time.
Okay.